Welcome to AETCM, the emergency medicine channel. It's a 52-year-old female, non-case of diabetes, paroxysmal AF, status post thyroidectomy 20 days back for medullary carcinoma, came to ER with complaints of hyperextended arm, like tetany kind of feature in the right arm for the past 1 day.
AF was due to hyperthyroidism.
Medullary carcinoma.
Okay.
So, initial 10-second assessment, airway was patent with no gargling, hoarseness of voice, breathing, respiratory rate of 18 per minute with saturation of 98%, bilateral air entry present, circulation wise, pulse rate of 60 per minute with S1, S2 present, BP was 130/70, disability wise, GCS was full with GRBS of 180, exposure, patient was affibrate. So adjuvant to primary survey, we did a VBG showing calcium of 0.67 and ECG also showing T inversion in V1 to VT, V1, V2 with the prolonged QTC and sinus bradycardia. With our since patient is having a decrease in VBG itself showing 0.65. For our VBG it is 1.15 to 1.25 is the normal range. So we came to with our initial assessment, there's a hypocalcemia for this patient. So patient was severely symptomatic. We give an injection IV calcium gluconate.
How much?
10%, 10 ml over 10 minutes. So this history of presenting complaint, it's a case of 52-year-old female, non-case of diabetes, history of paroxysmal AF, status post thyroidectomy was done 20 days back. Patient had a swelling in the thyroid. They did a biopsy showing medullary carcinoma. So they did a thyroidectomy 20 days back. Post which today morning patient suddenly developed.
Have they started calcium replacement?
Patient is already on shell cal and resveratrol.
Okay.
Patient on tablet, but still patient present with tetany. So it was like the symptoms was not painful kind of. It was not painful, but the spasm of fingers were there.
Okay.
With metacarpal hyperextension. There were no history of any fever, vomiting, tingling sensation over the tingling or numbness over the mouth, or any seizure kind of episodes, or any focal neurological deficit.
What was the respiratory rate?
Respiratory rate is 18 per minute. There
Is
were
it
no
important?
Yes, ma'am. Actually, hyperventilation can cause respiratory alkalosis, which can cause transient hypocalcemia.
Okay.
Patient can also become symptomatic due to respiratory alkalosis. But for this patient, respiratory rate was normal. So with our initial assessment and history and presenting complaint, we came to a diagnosis of initial provisional diagnosis of hypocalcemia. So labs. Secondary to parathyroid, like thyroidectomy, surgical removal of parathyroid. So lab we did use lab test showing total calcium of 5.17, but albumin was normal only. So
albumin was
normal. 3.1 was there. So since there is no hypoalbuminemia, so corrected calcium we don't have to calculate.
Okay.
It is 5.17 only. Then magnesium was 1.9.
Okay. What is the importance of magnesium in hypocalcemia?
So in case of parathyroid hormone, in hypocalcemia, there may be a concurrent hypomagnesemia. So we have to correct magnesium and due to parathyroid hormone.
Due to?
Parathyroid.
What is the relationship of magnesium to parathyroid hormone?
Calcium, parathyroid.
Magnesium is, if magnesium is not there, parathyroid hormone resistance can happen. That's why that is very important. But here there is no parathyroid hormone. So even if magnesium is low, that doesn't make any change here. Okay. If it is low, we have to correct it. But in this case, it is probably due to the removal of the gland itself.
So okay. So since it's a symptomatic hypocalcemia, we have to correct parenterally.
Okay.
Parental correction is we usually use calcium gluconate or calcium chloride. But
what is available in our hospital?
Calcium gluconate.
What is the difference between calcium chloride and calcium gluconate?
Elemental calcium is 93.
So it is very high dose. Triple time of
Calcium
the normal calcium gluconate is available. Where will you use that?
Calcium gluconate. Like beta blocker toxin, like other
massive transfusion.
massive transfusion.
For a massive transfusion only that is required. Otherwise, routine cases, calcium gluconate will be more than enough.
So in parenteral, like where we like IV correction is only done if there is severe symptomatic hypocalcemia along with like tetany, seizure, carpal pedal spasm with ECG abnormality, that is QTc prolongation or arrhythmia, or in corrected calcium if hypoalbuminemia of less than 7 to 7.5, or patient is not symptomatically improving even with oral calcium, we will give corrected with IV chloride, IV correction. So bolus doses we will add at 1 to 2 gram of or 20 to 20 ml of 10% 10% calcium gluconate in 50 ml of D5 water or NS that have approximately 90 to 180 milliequivalents of calcium. Will infuse over 10 to 20 minutes. Repeat infusion after 10 to 60 minutes if symptoms are still persistent.
This will act for how many hours? This initial bolus?
As in how long till correct?
Will act only for 1 to 2 hours. So most of these patients may require continuous infusion for at least 24 hours.
So infusion is how we do is like we'll add 11 gram, that is 110 ml of 10% to 890 D5 or NS, which have approximately 1 gram of elementary calcium. That is a total of 1 liter, that is 1 ml in 1. We will transfuse over 24 hours. That will infuse along with oral also we will give. And in only precaution is if patient is on digitalis, we'll take an extra care because overcorrection can cause hypercalcemia and digitalis toxicity. So in about calcium is the most important elements in our body. It's a total body of 15 gram per kg calcium will be there, and normal calcium intake should be 800 to 300 milligram daily we have to take. Its absorption is mostly by active using vitamin D or by passive, that is concentration dependent. Normal calcium concentration is 8.5 to 10.5. If it is less than 10, less than 8, we have to give correction. Symptomatic, IV parenteral, or if asymptomatic, we can give oral tablets. So, hemostasis of calcium is mainly by vitamin D, parathyroid hormone, calcitonin, and calcium-sensitive receptors in the plasma membrane of parathyroid.
Normally in hypocalcemia, if it is not surgery is not done, what investigation you do first? What are the basic investigation you do?
So if patient is having low calcium, we will go with parathyroid hormone levels. If parathyroid hormone is normal, and we also have to send RFT and
any other element?
Magnesium we have to send.
Magnesium, then
phosphate.
So calcium, albumin, phosphorus, creatinine, and PTH. These are the basic investigation you do, and you do a ECG also. So in basic investigation, if RFT is deranged, we will came to CKD can cause vitamin D deficiency, that can cause hypocalcemia. If and also hyperphosphatemia can cause hypocalcemia. Then if parathyroid hormone is low, that is hypoparathyroidism, which can cause hypocalcemia. We can supplement parathyroid. Hypomagnesemia can be concurrent with in hypoparathyroidism. Resistance of hypoparathyroid hormone can cause hypocalcemia as well as hypocalcemia. Then drugs causing. There are few drugs that can cause hypocalcemia, include phosphates like in enemas and laxatives. Then diuretics can cause. Then phenytoin, phenobarbitons. Then gentamicin, tobramycin,
Mycin groups can cause. Then some chemotherapy drugs like cisplatin can cause hypocalcemia. Then citrates, steroids. Then
Citrate toxicity is common in which type of like treatment in emergency?
Blood transfusion.
Blood transfusion. The eye citrate can produce massive transfusion protocol trauma.
Then magnesium sulfate, bisphosphonate,
Bisphosphonate
calcitonin,
is used in
osteoporosis.
Osteoporosis. Okay.
Then cinacalcet can cause
Cinacalcet is used in nephrology patients. You use where? Should know because we are using it. Should read about that. What else?
So in transfusion, during massive transfusion, blood is given if in a faster rate, that is 1 unit every 5 minutes, that is 10 ml of 10% calcium chloride can be given every 4 to 6 unit of blood, due to if patient is in
especially in stored blood, this will be common.
Preservative calcium.
Not in like immediate transfusion of whole blood product, it may not be very common, but we are getting only stored blood.
Then in calcium, gluconase is more preferred because of the low content, like calcium chloride have high content, as well as
So what
extravasation.
you anticipate while giving IV?
Calcaneus cutate, like
Thrombophlebitis.
thrombophlebitis.
Calcinosis cutis is seen in which condition?
Calcium.
You are telling unwanted things here. What is calcinosis cutis?
That is deposition of
which
calcium.
Which disease?
Hypercalcemia.
Calcinosis cutis is a part of
scleroderma.
What is the treatment for that? Calcium channel blockers can be tried, but it is not going to be effective. So don't tell unwanted things here.
And ECG changes in hypocalcemia is prolongation of QTC, which is mostly due to prolongation of ST segment, along with
So what is the complication of prolongation of QTC? When you see prolonged QTC, immediately we correct it, correct the calcium. If you don't correct, what will happen?
can lead to arrhythmias.
What arrhythmias? Arrhythmias is a very broad term.
Ventricular tachycardia.
Both QT shortening and prolongation lead to ventricular tachycardias. Torsades T point is. What is this Torsades T point is?
That is polymorphic VT.
Polymorphic VT. What is the pattern?
Like either peduncle,
Twisting
and turning around the axis.
What is the difference between bidirectional VT and Torsades D point is? Bidirectional VT, Torsades D point is. You are telling this is both directions. What is the difference?
This oscillatory movement is more in Torsades. Oscillation.
It goes like this, Torsades. Bidirectional VT. One is positive, one is negative. Each complex, you take one complex will be positive, other complex will be negative. Like that, if you see, that is bidirectional VT. Other one is many complex are positive and then many complex are negative. So twisting around the axis. How do you manage that?
Magnesium sulfate.
Magnesium sulfate. Okay.
Then and signs and symptoms. Hypocalcemia. So, symptoms and signs include weakness, fatigue, spasm of cramps. Neurological symptoms include seizures, tetany.
Abdominal pain is one of the common presentation. Then tetany,
cramps.
Then impaired sign means what?
Chosic sign. If we tap on the facial nerve, there will be spasm of the facial muscle. Chosic sign is when we keep the BP cuff for more than 1 to 2 minutes, there will be spasm of the our hands. Mostly these are due to hyperexcitability of the nerves. Then perioral or digital paresthesias, impaired memory.
The most common feature patient will come with is perioral numbness and tingling
Skin
sensation. That is the most common presentation.
Then hallucination, dementia, hyperpigmentation, weak or scaly skin. In some patient there will be ventricular arrhythmias, torsades, vasoconstriction, heart failures. In skeletal there will be rickets
Why
or
heart failure?
this muscle excitability, like prolonged cardiac relaxation.
Calcium is required for your
Cardiac contraction.
cardiac muscle contraction. Okay. So calcium, if there is hypocalcemia, definitely cardiac failure will occur.
Skeletal muscle osteodystrophy, rickets, osteomalacia, and miscellaneous like dental hypoplasia, cataracts, and decrease
That is
insulin
all
secretion.
common chronic
Chronic
condition.
conditions. Then treatment, parenteral or oral
What
calcium
happened to
tablets.
this patient afterwards?
After we given the calcium gluconate, symptoms gradually reduced.
Continuous
and,
infusion was started.
infusion was also started.
Started. But after that, it never came back.
And no,
came down.
when he was in ER, it never came back. Then
So what all
shifted
things
to
you can give to prevent further episodes?
strict calcium monitoring along with oral. After 24 hours, we'll start on oral calcium
Then what
supplementation.
else?
Then vitamin D supplementations also.
What else?
Oral
We have to see the parathyroid hormone.
Parathyroid
Levels
hormone,
are very low. We'll have to replace it. That also.
parathyroid.
Okay. Because here the reason may be hypoparathyroidism. That has to be corrected. Most of these post-surgery patients will come back with hypocalcemia. Even if they are replaced with calcium, they'll come back. They may be missing, we don't know. Actually, these patients should take 2 tablets, calcium tablet, 3 times. But many of the patients are taking suboptimal dose, 1 tablet daily or 1 tablet BD. That's why they are coming back with hypocalcemia. Okay.
Yes.